the Dysautonomia International webinar in recognition of Sjögren's Awareness Month, which is April. We are really pleased to be joined by a guest this evening, Dr. Brit Adler, who's an assistant professor of rheumatology at Johns Hopkins. She's involved with the Sjögren Center at Johns Hopkins, the Lyme research at Johns Hopkins, and the POTS research going on at Johns Hopkins, amongst other things. And she is the recipient of some Dysautonomia International research funding. She's doing some really great research. And so we've had, like, over the years, a bunch of talks on how Sjögren's causes autonomic neuropathy in some patients, and like a really deep dive on the dysautonomia piece of Sjögren's. But we've never actually had a lecture on Sjögren's overall. What is it? How is it diagnosed? What are the different symptom and organ manifestations? So we invited Dr. Adler to give us that kind of talk tonight. So I will stop talking and I'll pass it on over to Dr. Adler.
Good evening, everyone. It's a pleasure to talk with you tonight. Happy Sjögren's Awareness Month. So as Lauren mentioned, I'm an assistant professor at Johns Hopkins, interested in POTS in the rheumatic diseases, including Sjögren's. And I hope to talk to you today about Sjögren's, how it presents, how it's diagnosed and treated, so that all of you can be more aware of this syndrome and can know what to look out for. And I have no financial disclosures or conflicts. So first, I'm just going to give an overview of what Sjögren's is. And so Sjögren's is an autoimmune disease in which the epithelial tissue is targeted. And so what this means, an autoimmune disease is when your immune system is overactive or dysregulated, and instead of attacking germs like COVID or bacteria or the flu, it targets your own healthy tissue. And in Sjögren's, the immune response targets epithelial tissue. So it's also called epitheliitis, or inflammation of the epithelial tissue. The most prominent way that this presents is the immune system attacking glands. And so the major salivary glands are a major target of the immune response in Sjögren's. We all have three major salivary glands: the parotid on our lateral cheek, the sublingual gland under our tongue, and the submandibular glands under our jaw. The lacrimal glands are also targeted in Sjögren's. These are the tear-producing glands at the corner of our eyes. And then also the minor salivary glands are targeted in Sjögren's as well. And these are unnamed salivary glands that are scattered throughout our mouth. And it can also involve the nasal mucosa as well, leading to dryness of the nose. So this is the most prominent way that Sjögren's presents, but we have epithelium throughout our entire body, and it is in pretty much all of our organs. And so Sjögren's is much more than just a glandular issue. It can also affect the kidneys, the liver, the nervous system, among many other organs, which we're going to talk about today. So the most common symptoms of Sjögren's are dryness of the eyes and the mouth, and the medical term for this is called Sicca syndrome. Dry eyes can present as burning, itching, a gritty sensation in the eyes. Some people describe as having like a foreign body sensation, or like feeling like they have sand in their eyes. And having blurred vision or light sensitivity is also very common. Dry mouth can often present with thickened saliva. Patients often have difficulty swallowing, and saliva is actually incredibly important for dental hygiene. And so patients who have reduced saliva have a lot more increased cavities. Many patients have vaginal dryness. They can get swollen glands, fatigue, joint pain, and then neuropathic symptoms or nerve symptoms are also extremely common. So joint and gland symptoms are the most common symptoms, but really Sjögren's can affect any organ. And what's surprising to me about Sjögren's is the diversity with which it can manifest. And this is unlike other autoimmune diseases like psoriatic arthritis or dermatomyositis. It really targets a limited set of organs, but in Sjögren's, we can see pretty much any organ be affected. And so in addition to the joints and the glands, we also, in 12% of people, see pulmonary or lung involvement. We can see swollen lymph nodes. Some patients get cutaneous or skin involvement. The kidneys can be involved. And we also see neurological disease as well in our patients, which we'll talk more about. And in addition to these organ systems, there's also multiple reports of, of multiple diseases that are autoimmune diseases that are associated with Sjögren's. So we've seen autoimmune hearing loss in patients, interstitial cystitis, small fiber neuropathy and dysautonomia, and also some patients can get inflammatory eye disease as well. Raynaud's is also extremely common and affects about 15% of people. And so that can be very prominent in some people as well. So Sjögren's is more than just a dry eye disease, and it really is a multi-system disease affecting the entire body. So I want to talk briefly about the epidemiology of Sjögren's and who is affected by this. So the prevalence is about 0.1 to 1% of the population. So it tends to be a little bit less frequent than rheumatoid arthritis or lupus. It's heavily skewed towards females, which is similar to many other autoimmune diseases. So about 90% of patients are female. It can occur at any age, including there are pediatric cases of Sjögren's, but most often it's a middle-aged diagnosed in middle-aged women between the ages of 40 to 60. And it really is seen across all ethnic groups. There's some studies showing that it may be higher in American Indians, maybe less prominent in African Americans, but the data is mixed here, and we really see it across all ethnicities and races. And we also see in our patients a strong family history of autoimmune disease. And Sjögren's is not directly inherited. So it's not like we see a grandmother with Sjögren's, a mother with Sjögren's, a daughter with Sjögren's, but we see autoimmune disease in general in families. So for example, we might see a grandmother with lupus, a mother with rheumatoid arthritis, a daughter with Sjögren's. And so this autoimmunity in general tends to be enriched in these families, suggesting that there's some gene that predisposes to autoimmunity. So Sjögren's is a chronic autoimmune disease. It tends to not just go away, and it tends to progress slowly and have episodic flares. And so this is a little bit different from lupus or vasculitis, which can have very fulminant presentations. Patients can get rapidly progressive organ failure with these diseases, and we tend not to see that so much with Sjögren's. Often fatigue and joint pain are disproportionately prominent symptoms. And but patients can also develop new systemic manifestations over time. So just because someone presents with dryness and fatigue in the beginning, they're still vulnerable to getting new organ manifestations in the future. And so they need to be carefully monitored for these complications. Patients with Sjögren's do have a normal lifespan, although the disease does cause significant morbidity and reduced quality of life. And so from the patient perspective, this Sjögren's is a profoundly disabling disease and really does reduce quality of life dramatically. And studies consistently show that fatigue is the most disabling symptom among patients, even often more so than dryness, and it can be very life-limiting. We see a lot of chronic pain, sleep disturbances, and brain fog, and this contributes to poor physical and mental well-being. And many patients have an increased risk of going on disability. They have more difficulty working or performing their daily activities, especially when they're having flares. Sjögren's patients have high health services utilization, and they have high rates of depression, anxiety, and social isolation. So this disease really is disabling, and we need more research and more awareness among medical professionals about this disease. And I want to talk briefly about how Sjögren's nomenclature has changed over the years. So there's been a push to call Sjögren's disease instead of Sjögren's syndrome. So in the past, Sjögren's was called Sjögren's syndrome, and there's been a push to rename it because it was felt that syndrome made it seem like it was just a cluster of symptoms, but really Sjögren's is a defined pathological disease with a unique mechanism. And so the word disease is supposed to better reflects this. And also the word disease, I think also reflects that this is a systemic disease that is debilitating. And so many foundations and groups have kind of made a push to rename this to Sjögren's disease. In the past, we also used the term secondary Sjögren's, and there's now a push to avoid that nomenclature as well. So even as recently as a decade ago, when I was a fellow, when Sjögren's overlapped with other autoimmune diseases like rheumatoid arthritis or lupus or scleroderma, we would say that it was secondary Sjögren's. And I think this term implied that the Sjögren's was secondary in importance to the other diseases. But really, Sjögren's is its own distinct disease that overlaps with these other diseases. And so, so when I'm talking about Sjögren's, I usually, and if a patient happens to have rheumatoid arthritis, I'll say that it's Sjögren's overlapping with rheumatoid arthritis. So I want to talk about how Sjögren's is diagnosed. And Sjögren's is probably one of the trickiest diseases to diagnose of all of the rheumatic diseases. And in part, that's because the classification criteria involve diagnostic tests that are not readily available. And really, the classification criteria were designed for research use and are not really applicable to the real world clinical practice. So Sjögren's, the diagnosis of Sjögren's is a clinical diagnosis. And so what this means is that there is no one diagnostic test that you can get done that tells you whether or not you have Sjögren's. So ideally, the diagnosis should be made by a doctor, preferably a rheumatologist, who is incorporating all of your symptoms, your medical history, your exam, and your diagnostic testing to arrive at a diagnosis. And the classification criteria that's most often used for Sjögren's was developed in 2016 as a collaboration between the American and European rheumatology societies. And this classification criteria involves biopsy results, lab results, eye exam findings, as well as saliva production. And in order to meet the classification criteria for Sjögren's, you have to have a score greater than 4 once all of these diagnostic tests are incorporated. And like I said, this classification criteria is probably the most widely used classification criteria, but it has a lot of limitations. And the limitations are that some of these tests are not widely available in many rheumatology practices. And also this classification criteria was designed for research purposes. And so it's often not particularly useful or helpful in clinical practice. And so that's why when rheumatologists diagnose Sjögren's, it's often more of an art than a science. So now I'm going to go through all of these different tests that we use to diagnose Sjögren's so that you're more familiar with these different diagnostic tests. But first I want to talk about dry eye, because just figuring out whether your dry eye, what the cause of your dry eye is, can be complicated in and of itself, and not all dry eye is from Sjögren's. So there's two main causes of dry eye. One is deficient tear production, which basically means you're not producing enough tears. And one cause of that is Sjögren's, but more often than not, dry eye can be from non-autoimmune reasons. So this includes just aging. Your tear production drops off as you age. Hormonal changes can influence tear production. Medications can cause decreased tear production. So this includes antihistamines, decongestants, antidepressants. All of that can reduce tear production. We also see dry eye in other autoimmune diseases. So it's a common complaint in rheumatoid arthritis and lupus. And then the other cause of dry eye is increased evaporation from the eye. And so in this case, your body is actually producing enough tears. It's just evaporating faster than it should be. And the most common cause of this is meibomian gland dysfunction. So we all in our inner eyelids have these glands called meibomian glands. And these glands are responsible for secreting oil into the tear film. And if you have dysfunction of these glands or they become blocked and you have less oil secretion in the tears, this will lead to increased evaporative loss as well. There's other factors as well that can increase evaporation, including contact lenses, Even the frequency with which you blink can affect how much evaporative loss you have. And so it's really important to have a good ophthalmologist who can help you understand why you have dry eye and tease apart all of these different causes. So there's two diagnostic tests that are used to diagnose dry eye by ophthalmologists. So the most widely used test to measure tear production is called the Schirmer's test. And so for this test, a paper strip is placed at the corner of the eye. This picture shows the patient having their eye open, but actually typically the eye is closed. And this paper strip is kept in the eye for a total of 5 minutes, and we measure how much tears are produced. And so if there's more than 10 millimeters of tears on the strip after 5 minutes, that is considered normal. And if there's less than 5 millimeters of tears on the strip after 5 minutes, that is considered to be dry eye. And then, of course, there's always the borderline measurement of 5 to 10 millimeters of tears. So that is very helpful for actually quantifying how much tears you make and determine if you actually have dry eye. Then there's another very helpful tool called ocular surface staining. And this is done on a slit lamp exam. And this test assesses the integrity of your ocular surface, including the cornea and the conjunctiva and the tear film. And it looks for it looks at the integrity to determine if there's any damage from the dry eye. And so two dyes are used. Fluorescein dye is used to assess the cornea integrity, and lissamine green is used to assess the conjunctiva integrity. And there's a scoring system that I'm not going to go into. But basically, if your ocular surface score is greater than or equal to 5, that is very suggestive of Sjögren's. And this test is extremely useful. It actually picks, if your ocular surface stain is greater than 5, it actually is highly suggestive of Sjögren's. The problem with ocular surface staining is that it's very dependent on who's doing the test, and it's also not widely available by all ophthalmologists. So you do have to go to a good dry eye clinic that has experience with this test. And then the other test that's used to assess salivary production is called the unstimulated whole salivary flow. And this is about as simple of a test as you can possibly have. Basically, patients drool into a cup for 5 minutes, and we measure how much saliva is produced over 5 minutes. And a person without dry mouth makes over 0.5 mLs of saliva over 5 minutes. And if it's less than that, then you're considered to have less salivation than you should. And this is important to determine if patients are actually producing less saliva than they should, or whether they have just the sensation of having a dry mouth, which is called xerostomia. Even though this is probably one of the simplest tests that I can possibly think of, it still requires a scale. And so it's actually not available in many rheumatology practices. And so in that sense, it actually is not particularly helpful, but it still can be an important part of diagnosing Sjögren's. And the other limitation of this test is that it can be influenced by medications. So if you're on antihistamines or anticholinergics, this can reduce your saliva flow and lead to an abnormal test. And then sort of the gold standard test for Sjögren's is a minor salivary gland biopsy, which is also called a lip biopsy. So for this test, the doctor will take out one of the minor salivary glands on the inner lip. It's a very minor, easy surgery in which they just make a minor incision and take out a salivary gland, and then a pathologist looks at it under the microscope. This procedure, it tends to heal very well, and there's very few long-term complications from this surgery. And what the pathologist is looking for is how many foci of lymphocytes there are. And so in Sjögren's, there are clusters of lymphocytes, which are one of the body's immune cells. And the pathologist will count how many of these discrete clusters there are. And you can see in this picture, the black arrows are pointing to each foci there, and you can see all the purple dots are all the lymphocytes that are attacking the salivary gland. And so if the focus score is greater than or equal to 1, this is consistent with Sjögren's. You do need to make sure that there isn't another disease that can cause lymphocytes in the salivary gland. And so your doctor should make sure you don't have sarcoid or amyloidosis or IgG4 disease, all of which are inflammatory disorders. Also, HIV or hepatitis C are infections which can also mimic Sjögren's. So your doctor should make sure you don't have that as well. When the biopsy does not show these discrete foci of lymphocytes, the other most common pathology that we see is nonspecific sialadenitis, which is basically just nonspecific inflammation in the salivary gland, or sialadenosis, which is enlargement of the salivary gland, but no inflammation. And these are kind of nonspecific findings. It's not consistent with Sjögren's. And this sialadenitis and sialadenosis can be seen in healthy people. The limitations of the salivary gland biopsy is that there's several limitations, and one is that even healthy people can have a positive lip biopsy, and it's estimated that roughly 10% of healthy people actually can have a focus score greater than 1 on their lip biopsy. The higher the focus score, the less likely it is to be present in healthy people. So I think it's mostly healthy people. This 10% of healthy people who have a positive lip biopsy, most of them have a focus score of 1. And the other problem with these lip biopsies is that there's very poor inter-rater reliability, which basically means that different pathologists disagree looking at the exact same slide. And it's been estimated that if patients get a second evaluation by an expert at another center, it changes the diagnosis in about 50% of cases. So this is a huge problem with getting biopsies. And I think it highlights that we need a lot more education and standardization between pathologists. And most of the discrepancies when pathologists disagree are for these borderline cases where patients may have a focus score of 0 or 1. Usually when there's a focus score of 5, most pathologists will agree on that. There's a lot of research right now in using salivary gland ultrasound or MRI to visualize the salivary glands to diagnose Sjögren's, so we don't have to put patients through lip biopsies. So there's a lot of research on this, but it's not quite ready for prime time yet, and it's not quite ready to replace the lip biopsy. But you can see in these pictures here, on the top panels, you can see the parotid gland and the submandibular gland in a normal, healthy person without Sjögren's, and you can see there's a nice kind of homogeneous gray color. And then as you go down, you see the different grades of severity in Sjögren's, grade 1, grade 2, grade 3. And you see various structural abnormalities emerging, various hypoechoic areas, and abnormal salivary gland texture. So the other diagnostic tool that's very important for diagnosing Sjögren's is autoantibodies in blood work. So about 80% of patients with Sjögren's have a positive ANA. And so a positive or checking an ANA can be important in the diagnostic evaluation for Sjögren's. Now, I'm just going to back up a little and explain what an ANA is, because it's probably one of the most common consultations I get as a rheumatologist. So ANA stands for anti-nuclear antibody. And basically it means that when a patient has a positive ANA, it means they have some antibody in their blood that's binding or targeting something in the nucleus of the cell. So as you can imagine, this is a very non-specific test. So many healthy people walking around have positive ANAs. And so it doesn't help so much make the diagnosis, but it can be a sign that there's something autoimmune going on when it's positive. And the titer of the ANA really does matter. So when the lab technician reads the ANA in the lab, what they do is they put your serum or your blood on a cell line, and then they visualize it under a microscope and see what your blood is binding to on that cell line. And you can see in these pictures, these are all different types of patterns of ANAs that can be observed. And you can see that there's different patterns depending, there's different patterns of ANAs, so speckled, homogeneous, mixed. And the technician also notes how bright it is, so how strong that ANA is. And the titer really does matter. So sometimes the lab will report a titer of 1 to 40 or 1 to 80, which means that it's a really faint titer, and it's not really lighting up that much. That tends to be much less clinically significant than much higher titers where it's really, really bright and there's a very strong antibody binding. So about the other antibodies that we check that are a little more specific for Sjögren's are Rho antibodies and Law antibodies, which are present in about half of patients with Sjögren's. So these Rho and Law antibodies are commonly referred to as the Sjögren's antibodies. The problem is that they're actually not specific to Sjögren's. So Rho and Law antibodies are actually quite common in other autoimmune diseases. They're very common in lupus. We sometimes see them in rheumatoid arthritis, myositis, scleroderma. So they're not very specific at all. That being said, they are often present in Sjögren's, and especially if a patient has dryness, it can be very indicative that they have Sjögren's. Law antibodies without Rho are not associated with Sjögren's, which is why they're not in the classification criteria. We also see about half of patients having rheumatoid factor, which is one of the most common antibodies in rheumatoid arthritis. And just as a little side note, we tend to not track antibody levels over time. So once a patient has an antibody, usually it stays. Sometimes it can go away, but it usually doesn't add much value to track the titers over time. And then there's a lot of research into discovering novel autoantibodies in Sjögren's. So about a third of patients with Sjögren's are seronegative, meaning they don't have Rho-Law antibodies, and we can't find any antibodies. And just because they don't have antibodies doesn't mean that those antibodies don't exist. So there's been studies of seronegative Sjögren's patients, and even though they don't have Rho-Law antibodies in their blood, you can actually identify Rho-Law autoantibodies in their saliva and their tears. And recently, there's been a discovery of some novel Sjögren's antibodies targeting salivary gland protein 1, carbonic anhydrase 6, and parotid secretory protein. And so there's now a commercially available panel for these that you can get checked. These antibodies may be useful for diagnosing Sjögren's earlier in the disease, and they sometimes are present in patients who don't have Rho-Law antibodies. So they may have some value, but we're still, a lot more research is really needed to validate these antibodies and understand when they're clinically useful. So just to revisit the classification criteria, now that we've talked about all of these different diagnostic tests. So going into the classification criteria are the lip biopsy results, the Rho antibodies, and the lip biopsy and the Rho antibodies are very heavily weighted. So if you have either one of those are positive, you get 3 points for either of those. And then you get a point for having a high ocular staining score, a high Schirmer's test, or not, sorry, an abnormal Schirmer's test, or an abnormal salivary flow rate. And so if you have a score greater than or equal to 4, after factoring in all of these weighted scores, then you meet classification criteria. And so you can see that it's heavily weighted towards having an abnormal biopsy or having a Rho antibody. And of course, when you make a diagnosis, you always want to make sure that there isn't a mimicker of Sjögren's. So patients should always be asked about, or you should always ask about having a history of head and neck radiation, which can cause dryness, active hepatitis C infection, HIV, sarcoidosis, amyloid, graft versus host disease, and IgG4 disease are all can all mimic Sjögren's. So now I want to kind of shift gears and talk more about how Sjögren's can affect the various organs in the body. And I want to go through each of these and talk more about how these different manifestations can present. So about 50% of patients with Sjögren's have joint pain. And roughly a third to 40% have an inflammatory arthritis. And this means that they have joint swelling, inflammation, stiffness in their joints. The arthritis in Sjögren's is often symmetric, and it affects multiple joints, including the small joints and the large joints. So often it's the joints in the hands, the elbows, the shoulders, and it has a pattern that resembles rheumatoid arthritis. It's typically non-erosive, so when we do x-rays of Sjögren's patients, typically we do not see erosions, which is distinct from rheumatoid arthritis, where we commonly see erosions or damage to the joint on x-ray. And it can sometimes be difficult to distinguish between Sjögren's with inflammatory arthritis and rheumatoid arthritis. So if you remember, a large number of our Sjögren's patients have rheumatoid factor, which is one of the antibodies we see in rheumatoid arthritis. So if you have a Sjögren's patient who has rheumatoid factor and inflammatory arthritis, it can look a lot like rheumatoid arthritis, and sometimes it can be very difficult to tease apart whether this is primary Sjögren's or whether it's Sjögren's overlapping with rheumatoid arthritis. Sjögren's can also affect the lung. And what's striking to me is how diverse the manifestations are of lung disease in Sjögren's. So it can manifest in numerous ways. We see bronchiectasis, which is a chronic lung condition that makes the airways permanently dilated. Some patients get interstitial lung disease, which is caused by lung inflammation and scarring. We see bronchiolitis, which is inflammation of the little bronchioles. Some patients get pulmonary nodules or areas of lymphoid tissue built up in their lung. We see organizing pneumonia, cystic lung disease, pleuritis, which is inflammation of the lining around the lung. Very occasionally, we'll see pleural effusions or actual fluid in the lung. And then some people also can rarely get pulmonary hypertension, where there's elevated pressures in the pulmonary arteries. So Sjögren's does not affect the lung in only one way, and it has very diverse manifestations. And some people also, roughly 10%, can get skin involvement. And again, it has a wide array of presentations when it affects the skin. Many people just get dry skin. And so that is extremely common in Sjögren's. We also, this is less common, but we do see some patients who get a skin vasculitis, where there's inflammation of the blood vessels in the skin. And it causes a very distinct rash, which you can see on the top panel, where there's raised red spots called palpable purpura. And the most common type of vasculitis we see is called a leukocytoclastic vasculitis. Sometimes the rash, the vasculitis can look almost urticarial, like hives that don't go away. And then other dermatologic manifestations are erythema, annular erythema, erythema multiforme, which is in the bottom panel. So again, it has very diverse cutaneous manifestations. And then many patients also get Raynaud's. So about roughly a quarter or so of patients have Raynaud's. Raynaud's occurs from vasospasm of the blood vessels, resulting from cold temperatures. And to have classic Raynaud's is where you get triphasic discoloration of the fingers in response to cold. So at first you get white fingers from the vasospasm, then blue because there's not enough oxygen. And then once the vasospasm ends, you get the finger can turn red as the blood flow returns. And you should always be very, Raynaud's is common in young people, but when it starts later in life in older people, that is a sign that there could be something autoimmune going on when Raynaud's starts later in life. In Sjögren's, patients who have Raynaud's that is severe often have anti-centromere antibodies, which if you remember, that's one of the patterns that can occur on the ANA. And centromere antibodies are often found in scleroderma patients who have Raynaud's as well. And when we see centromere antibodies in Sjögren's along with Rho antibodies, those patients tend to have a lot of lung and liver disease. Now, one of the more dreaded complications of Sjögren's is lymphoma. So patients with Sjögren's have a 10 to 15 time increased risk of lymphoma throughout their life. Roughly 5% of patients will develop lymphoma in their lifetime. Usually it's non-Hodgkin B-cell lymphomas. Malt lymphoma is the most common. We also see diffuse large B-cell lymphoma, which is more aggressive. And the lymphoma typically occurs years after patients have had active disease for years. Males tend to be more at risk. Patients with a lot of parotid gland swelling are at higher risk, or patients with enlarged lymph nodes. Those who have more disease activity on their lip biopsy tend to be at higher risk, so those with a focus score greater than 3, and those who have a lot of lab abnormalities, so low complements, rheumatoid factor, et cetera, tend to be more at risk. And if patients, if there's any red flags, so if a patient is having weight loss, fevers, chills, their salivary gland is persistently swollen and not going down, or it's asymmetric and it's only swollen on one side, those are all red flags for lymphoma, and that should prompt a biopsy. All right, and so now I want to touch on neurologic disease in Sjögren's. So neurologic disease is probably a much more, it's an underappreciated complication of Sjögren's that is probably extremely common. And it again can present in a very diverse array of manifestations. So the neurologic disease can precede the classic dryness symptoms. So just because a patient does not have sicca or dryness does not mean they can't have neurologic disease. And we see central and peripheral nervous system manifestations. So when the central nervous system is affected, that can affect the spinal canal and cause transverse myelitis. We see inflammation of the optic nerve or optic neuritis. Patients with Sjögren's are more likely to have white matter changes in their brain, and occasionally they'll get aseptic meningitis or inflammation around the lining of the brain. And then we also probably more commonly see peripheral nervous system manifestations of Sjögren's. So, and this, again, is a very diverse array of manifestations. Some patients can get a sensory ganglionopathy. There's axonal sensory motor polyneuropathy, vasculitic neuropathy, where there's inflammation of the blood vessel that leads to nerve damage. We see demyelinating disease, cranial neuropathies causing facial nerve issues and trigeminal nerve issues. And then we also see small fiber neuropathies and autonomic neuropathies. And so I'm not going to go into too much detail because this is outside the scope of this talk, but this is a list of all of the different peripheral nervous system manifestations in Sjögren's and how they can present. And they can, a lot of them cause severe sensory symptoms, numbness, tingling, weakness, electric shocks, temperature sensitivity. And so the point here is that you really need a good neurologist to help if you're a Sjögren's patient who's having new neurologic symptoms, to do an exam and try to tease apart what's the most likely diagnosis. EMG nerve conduction studies can be very helpful for most of these. Although small fiber neuropathies typically have a normal EMG nerve conduction study. And so that's where a skin biopsy is important. So it can actually look at the density of the small nerve fibers. And then certainly for autonomic neuropathy, you have to get more specialized autonomic testing like a tilt table or QSART. And so small fiber neuropathies have different patterns based on their distribution. The more classic small fiber neuropathy that's common in the population is a length-dependent small fiber neuropathy. So that's what we see with diabetes, and it typically affects the hands and feet and more distal extremities in a stocking and glove distribution. But in Sjögren's, we can also see non-length dependent small fiber neuropathies. And so this has a patchy distribution. So patients will get nerve involvement in patches. So it can be on the face, the chest, the leg, the arm, and there isn't a clear distribution. And then some people just have diffuse neuropathic involvement. And so this is more typical of this is kind of what we see in patients who can have like fibromyalgia, which sometimes rheumatologists will diagnose patients with. On exam, patients with small fiber neuropathy have loss of temperature or pinprick, and it's important to rule out other causes, or especially reversible causes of small fiber neuropathy like diabetes and vitamin deficiencies. And like I said, the EMG nerve conduction study is usually normal, so you have to get a skin biopsy. And so many patients with Sjögren's can have, who have non-length dependent small fiber neuropathies, actually can have inflammation of their ganglia called a ganglionopathy. And I just want to talk briefly about this because it's very interesting. So the dorsal root ganglia is a cluster of nerve cell bodies that runs down on the side of the spinal cord. And the dorsal root ganglia is responsible for transmitting sensory signals from the environment or from the skin and transmitting it through the spinal canal up to the brain so you can process those sensory signals. And when some patients with Sjögren's can develop inflammation of that dorsal root ganglia, and this can lead to a ganglionopathy. And this can cause a variety of sensory symptoms. Patients can get sensory deficits, loss of sensation, pain. Sometimes they can actually get ataxia where they don't walk properly and lose balance because they don't have that sensory input. And Dr. Julius Birnbaum, who used to be at Hopkins, he did MRIs of Sjögren's patients with neuropathy and showed that on MRI that there was actually inflammation of their dorsal root ganglia on MRI. And he published a very nice paper showing that inflammation in the dorsal root ganglia on MRI actually improved after giving patients IVIG. So this is an important neurologic complication of Sjögren's. And then I would be remiss if I didn't talk about autonomic neuropathies or dysautonomia in Sjögren's. So this is likely an underappreciated peripheral nervous system complication of Sjögren's. As all of you are probably well aware, the autonomic nervous system controls various functions throughout your body. So the parasympathetic nervous system controls functions that are more calming. So it stimulates saliva, lowers your heart rate, stimulates gut contractions, whereas the sympathetic nervous system is more flight or fight responses. So it raises your heart rate, shuts down your gut contractions, etc. And patients with Sjögren's can have involvement of their autonomic nervous system, and it can lead to a wide various complications. So more than 50% of patients with Sjögren's report having autonomic symptoms on the Compass 31, which is an autonomic questionnaire. Some other studies have shown that patients with Sjögren's, 30 to 40% have abnormal heart rate variability, which is a measure of dysautonomia or autonomic dysfunction. And this is associated with the degree of fatigue that the patients experience. We still don't know the true prevalence of POTS or orthostatic intolerance in Sjögren's, because there haven't been too many studies of patients getting autonomic testing for this. But anecdotally, I personally manage a lot of patients who have Sjögren's and POTS, and so it does seem to be a complication of Sjögren's. And what's really interesting is some studies have found muscarinic antibodies in Sjögren's patients. And so these are antibodies that target the muscarinic acetylcholine receptor. And so this suggests that at least in some patients, there could be an autoimmune component underlying their dysautonomia that's kind of interrupting with autonomic signaling and leading to dysautonomia. But obviously more research needs to be done in this. And so if you look at organ involvement and blood markers in Sjögren's, you can see that, that patients with skin involvement, hematological complications, lymphadenopathy, they tend to have more abnormal blood work in Sjögren's. So those patients tend to have Rho, LA antibodies, ANAs, rheumatoid factors. But then patients who get more neurological disease, peripheral and central, they tend to be seronegative and have negative Rho LAs and sometimes even negative ANAs. And so this brings us to the seronegative Sjögren's patient, which are patients with Sjögren's who are negative for Rho LA antibodies. And so these patients are the most challenging patients to diagnose. They tend to be older. patients, and they tend to actually be more symptomatic. So they have more fatigue, more widespread pain, and they're more likely to have neurologic symptoms, especially small fiber neuropathy and ganglionopathy. And this is, like I said, this is the most challenging patient because to diagnose because this cannot be diagnosed based off of blood work. And this leads to a lot of diagnostic delays. And these patients are often misdiagnosed as having fibromyalgia, chronic fatigue, or an idiopathic neuropathy. And really, to meet the 2016 classification criteria, because they don't have Raynaud antibodies, to meet that criteria, a lip biopsy has to be done in order for them to meet criteria for Sjögren's. And so this, of course, brings up a huge diagnostic challenge for POTS patients. So more than 2/3 of patients with POTS have dry eyes or dry mouth, and they're often seronegative. They don't have Raynaud antibodies. And we know that autonomic neuropathy is an incredibly common complication in Sjögren's. And so the question is always, when do we do a lip biopsy and pursue this Sjögren's workup for a POTS patient? And there's really no clear guidelines. We have one study to guide us here, and that's a retrospective study of 161 lip biopsies that were done at the Cleveland Clinic among their POTS patients. And even among patients who the doctors thought may have Sjögren's, so had a high likelihood of having Sjögren's, only 11% of the biopsies were positive for Sjögren's. But what the authors found was that a positive ANA and small fiber neuropathy were associated with having a positive lip biopsy. So that might provide some guidance as to who we should try to do lip biopsies among. Interestingly, it was not patients with positive Rho antibodies who are more likely to have the lip biopsy, a positive lip biopsy, showing that these patients with POTS who have Sjögren's are more likely to be seronegative and not have the Rho antibodies. And so I think in my own practice for these patients, it's really important to have a good dry eye exam. So ideally with ocular surface staining, and that can provide really helpful information to know if there's actual impaired tear production and the cornea or the conjunctiva integrity is impaired, and that can help determine who should move forward with the lip biopsy. So I'm going to briefly, I know I'm running out of time, I'm going to briefly talk about treatments here. And I'm not going to go into too much detail on this, but basically for dry eye management, the basics is to eliminate any offending agents or medications that could be contributing. We start patients on artificial tears, ocular lubricants, make sure you have good lid hygiene and use warm compresses. And then if that doesn't work, then there's more advanced therapies that can be done. I'm not an ophthalmologist, so I'm just going to breeze through this because I think you'll probably be getting a talk in the future from an ophthalmologist on this. But there are a lot of more advanced therapies that can help with dry eye. For dry mouth management, you should avoid anticholinergic medicines like Benadryl, oxybutynin, and some tricyclic antidepressants. Regular dental care is incredibly important, using fluoride in toothpaste, good oral hygiene so you don't get thrush. There are saliva substitutes, gels, lozenges that can stimulate saliva production. Sugarless gums and hard candies containing xylitol also can stimulate saliva. And then for when all of that does not work, there are drugs that can increase saliva. They're called pilocarpine and cevimeline. And these drugs bind to and activate the muscarinic acetylcholine receptor and increase saliva production. And then there is a role for immunosuppression or immune treatments for Sjögren's. And really this we choose immunosuppression based off of the organ system that's involved. So if patients have recurrent salivary gland swelling, inflammatory arthritis, lung inflammation, skin involvement, lymphadenopathy, kidney involvement, muscle inflammation, or sometimes some of the nervous system complications, that is a reason to start immunosuppression. There's multiple immunosuppressants or immune treatments that can be used for Sjögren's. For more mild disease, Plaquenil or hydroxychloroquine can be considered. And then when it's more severe, that's when we reach for immunosuppressants, which are oral drugs like methotrexate, azathioprine, or mycophenolate or Cellcept. And if those do not work, or if the patient has very severe organ disease, then we reach for the infusions. And so this includes rituximab, which depletes B cells, cyclophosphamide, which is a very aggressive treatment that we usually only reserve for severe life-threatening or organ-threatening disease. And then also, we do sometimes use IVIG, particularly for neurologic disease. This is a little bit controversial, but there is a lot of data showing that for some neurologic disease, IVIG can be helpful. All of these immunosuppressants have not been shown to be helpful for improving fatigue or dryness. And so we do not use these medications to help with those symptoms. We really do reserve it when there is clear organ involvement. And Plaquenil or hydroxychloroquine is one of the more widely used medications in Sjögren's. It is an anti-malarial with an immunomodulatory effect, so it doesn't actually suppress your immune system and increase your risk of infection. It more modulates your immune system. And we use it often in lupus and rheumatoid arthritis. It has a very favorable safety profile. So we have a low threshold to try it in Sjögren's, and it's pretty safe. The main toxicity is that it can affect your retina after long-term use, so patients need to get regular eye exams while on Plaquenil. We have some randomized controlled trials showing that it does not improve dryness in Sjögren's, but it may help when there's joint pain, and it also may help with fatigue. And so doing a trial of Plaquenil in Sjögren's is very reasonable to see if it may help if you're having joint pain or fatigue. We have no data showing that it actually changes the disease course and is a disease-modifying therapy, but there is good data showing that it improves lab abnormalities. And so if you do a trial of Plaquenil and you don't notice any clinical improvement, some physicians will recommend continuing the Plaquenil, hoping to slow progression of the disease. But that's still very controversial, and we still need more studies. We still need more studies to show if that's the right thing to do. And in my last slide here, I just wanted to show this trajectory of clinical trials in Sjögren's, because I think this is really exciting. This is a slide that's courtesy of Dr. Alan Baer in the Hopkins Sjögren Center, and you can see that there is a lot of momentum right now for clinical trials in Sjögren's. So it's a very exciting time. We've gone for decades with very few clinical trials, and you can see that recently, over the past 5 years, there's a lot of interest in developing a drug for Sjögren's, and there are numerous trials ongoing right now. And so I'm very hopeful that in the near future, hopefully we will have a drug that is a FDA-approved disease-modifying therapy for Sjögren's. So in summary, Sjögren's is a systemic autoimmune disease affecting multiple organs that requires multidisciplinary care. We don't have an FDA-approved disease-modifying treatment, but it is important if you have Sjögren's to get diagnosed and to be monitored closely so you can prevent or catch complications early. And I think that a lot more research is needed to understand particularly neurologic Sjögren's, including dysautonomia, and how to treat it. I want to thank all of my colleagues in the Hopkins Potts Clinic who see patients with me, as well as Dr. Alan Baer and Dr. Thomas Graderbeck in the Hopkins Sjögren Center. And I want to thank Dysautonomia International for inviting me tonight to speak with all of you about Sjögren's, and happy Sjögren's Awareness Month.
Thank you so much. That was really, really informative and helpful to, I think, probably everybody tuning in. We have a lot of questions. I know we don't have a lot of time, but I wanted to try to jump into some of the more common questions people are bringing up. Just to let our guests know, we can see all of your questions. They don't all display to everyone. So there's like hundreds of questions. So we definitely can't get to all of them, but we'll try. Um, do you see involvement of the liver in Sjögren's?
Yes.
Yeah.
So there's primary biliary cirrhosis, also autoimmune hepatitis, and it's more common when there's anti-centromere antibodies. So that
Yeah.
is a well-known complication that we see.
So someone shares a little bit of their family history that they have like multiple generations of relatives that have had small fiber neuropathy, dysautonomia, and Sjögren's, and they say, how can this happen when there isn't a gene?
So I think that there may not be like one specific gene for all of that, but I think that there are genes that increase our risk of autoimmunity. And I think this is well described that some patients may have a gene that increases your risk of having autoimmune disease. And then you also need an environmental factor that triggers that autoimmune disease, whether that's an infection like COVID or what have you. But I think there's no doubt that that family probably does have some gene that's some pro-inflammatory gene that increases the risk of autoimmunity.
Yep. I'll share my own personal experience too. I have Sjögren's with dysautonomia. My dad has a Sjögren's-like phenotype with dysautonomia. We both have small fiber neuropathy, and his sister had definite Sjögren's as well. And we don't have any known Sjögren's gene, but I'm sure we have some gene running in the family that just makes that risk factor be there. And in POTS research, we actually did a small genetic study looking at HLA genes in POTS patients. These are the human leukocytic antigen genes that sort of help program the immune system. And people with POTS had a higher rate of HLA markers that are associated with lots of different autoimmune diseases. So it's like a risk factor gene. It doesn't definitely mean you're going to get a specific autoimmune disease necessarily, but and I just think it means we need more research. There are genes, we just haven't found them yet.
Mhm.
Let's see, this is another good one. Can a salivary gland biopsy make dry mouth worse when you're recovering from the biopsy?
Anything's possible, but I have not. Um, I would not say that's something that I've commonly seen.
Yeah. I had it done. It's not a fun test, right? It's not like a simple thing. You just get a blood draw and you're done with it. It's a little unpleasant. I would say if you're going to get one, my magic trick was to get chloroseptic numbing throat spray and just spray it on your biopsy site before you want to eat because it hurts for a few days. Um, I had a little inflammation there for a little while, and it maybe gave me a sensation of dryness, but I don't think it was actually dry. It was just like an unpleasant sensation for a few weeks. But mine healed fine. Here's another one. Can erythromelalgia be caused by Sjögren's or associated with Sjögren's?
Oh, that's a good question. I mean, erythromelalgia is definitely associated with autonomic dysfunction. I see it a lot in POTS. So I think it's likely associated. I'm not sure it's caused by Sjögren's, but I think it's likely associated, just like autonomic neuropathy is associated as well.
Yeah. Can neuropathy or dysautonomia affect your lungs?
Sorry, what is the question? Can
Can
neuropathy?
neuropathy or like dysautonomia or other types of neuropathy affect the lungs?
Not in the way that Sjogren's affects the lungs. So if you have inflammation seen on a CAT scan, like interstitial lung disease or bronchiectasis, that would not be caused by dysautonomia.
Right. But you do have lungs in your nerves and you have lungs that control the blood vessels in your sorry, you do have nerves in your lungs and you have nerves in the blood vessels throughout your lungs. So I think that the area of like, neurogenic inflammation in the lungs and things like that is not super well understood. It's probably most understood in the context of like asthma or COPD. But there have been some papers, also some of your central nervous system or brain stem regulation that controls your autonomic function also does play a role in respiratory function. But I don't think it's really well understood in the context of most dysautonomia diagnoses.
Mhm.
Let's see what else. We've got so many questions here. I'm trying to find ones that are like maybe broadly. Um,
Sorry, I went so late.
that's okay. It was such a good talk. Do you see pancreatic involvement in Sjogren's?
Rarely, but yes. Yeah, that was on the very,
I saw it was in the circles slides. Yep.
yeah, it was in the circle slide here.
Up in
Acute
the top right,
pancreatitis,
top left.
0.6%. It's not common though, by any means.
Yeah. Um, can a positive SSA point to other diseases in the absence of dry eye? Like, or are there other things to consider if you have elevated SSA?
Yes, so SSA is actually quite non-specific. So it is really common in lupus, it's common in myositis, we see it in rheumatoid arthritis. So it by no means is specific for Sjögren's. It's actually one of the most common antibodies we see across all rheumatologic diseases. And if you don't, so that's why a good rheumatologist will do a really thorough history, look at all of your symptoms and examine you to see if there's any signs or symptoms that might be pointing towards another autoimmune disease. So, if you have weakness and a positive SSA, you could have myositis, or if you have mouth sores, that might point towards lupus. And so that's why a really thorough exam and a review of systems is important.
Yeah. Does Epstein-Barr or other viral infections maybe trigger Sjögren's or have any relationship to the ongoing inflammation?
That's a very good question. I don't think we know. There's a lot of interest in actually infections potentially triggering Sjögren's or making Sjögren's flare. I don't think we know that much about Epstein-Barr virus in particular, with Sjögren's. So I think we need more research on this, but it's definitely an area that people are interested in, whether infections, including EBV, can cause Sjögren's.
Yeah. Does anyone with Sjögren's ever go into remission?
Yes. So patients can go into remission, and it's basically, and what that means is basically their dryness can get better and no longer become an active issue. We don't really think that the Sjögren's necessarily completely goes away, but it definitely becomes quiescent, and patients may be more at risk of having a flare in the future, but they can go through a prolonged period of kind of quiescence where the symptoms are not as active.
Yeah. Can you talk a little bit about the early Sjögren's panel and what I think there's different doctors using it to mean different things, but what is your approach to that panel? I know you had a little slide on, but I got a bunch of questions about it.
Yeah. Oh gosh. So we need a lot more research here. And I'm not going to give you a definitive answer here because we just need more research. I think I mostly use it when I'm on the fence about the diagnosis. So especially if it's early Sjögren's, patients are seronegative. I'm not confident I'm not confident with what's going on. I'll use it as an additive piece of information. But it's not widely validated for Sjögren's, and it doesn't factor into the classification criteria, so it isn't really widely recognized, but I think it is helpful for early Sjögren's in patients who are seronegative.
Yeah. I've been involved in a little bit of research on that and hoping to do some follow-up studies on it. I think what we really need to show is that finding a subset of patients who have some positive level of those antibodies early in the course of disease when they're not meeting the sort of official diagnostic or clinical research criteria, which I know you mentioned, they're not really meant to be diagnostic criteria. What's published for Sjögren's is meant to be like research criteria. But taking patients who have those early biomarkers and then following them long term to see if they actually develop the more official Sjögren's, I think that would help give validity to using the tests. And in addition to those antibodies, there are other antibodies that have been described in a lot of Sjögren's patients that they're not part of any clinical or diagnostic testing. So I think we just need a broader search for earlier biomarkers.
Yeah,
And
and the other thing that I've also struggled with the titers. So when I checked it, sometimes you'll get a really low titer of an antibody, and these panels check for multiple antibodies, so it's not uncommon to get a low titer of something and not really know what to do with it. So that is a challenge, and I think that's why we need more studies looking at these antibodies, like you said, and then prospectively following the patients and see if they develop, and see what they develop in the future, but also just looking at the titers so we can validate what is clinically meaningful.
Do you see mast cell activation syndrome in some of your Sjögren's patients? And does their mast cell stuff get better when you treat them for Sjögren's?
Yes, I do see mast cell. We do have some patients who get hives and certainly like gut sensitivities. I would say, that's a good question. Does it get better as you treat them? I mean, most of the time I'm giving Plaquenil to these patients, and I don't think that it's quite as effective as other mast cell treatments for the few patients that I'm thinking of right now. I'm not entirely sure if the immune therapies for Sjögren's helps with the mast cell.
Yeah. Well, there's other questions here. They're so good. I think that I'll download the questions that everyone asked and try to get Dr. Adler and I, and maybe we'll pull in a couple other doctors to help because it's a lot of questions, to try to get as many of these answered. And we'll put maybe post the answers when we post the video, because it's such good questions. And the range of organs and systems and comorbidities the questions are about just speaks to how complicated Sjögren's can be and how many different ways it can present in different people, and the need for more education on this. So thank you so much for sharing your evening with us, Dr. Adler, and thank you for the work you're doing on behalf of all of these complex chronic illness patients. And thanks to everybody who tuned in. Before I let you go, I want to plug, we have Dysautonomia Advocacy Day coming up on Capitol Hill on May 7th. And we're going to be pushing for more dysautonomia research funding, more clinician education, so our patients can actually get diagnosed and treated. We're pushing for adoption of the SSI Savings Penalty Elimination Act, which will allow people on Social Security income to have more savings without the risk of losing their benefits. And that's really important to our patient community because a lot of people with chronic illnesses like dysautonomias and Sjögren's and EDS do rely on Social Security payments to sort of pay their essentials. So I hope people will join us on May 7th. You can find out about it on our social media channels and our website. And then also we have a CME course at Stony Brook that's online and in person. It's a POTS CME course. We're also going to have EDS and mast cell speakers on April 26th. And then our big annual conference is July 11th to 13th in Raleigh. And it's a really amazing event if you can get there in person. We also have a live stream option for those who can't make it in person. So I hope to see everybody on future events. We all keep learning together. And yeah, thanks so much, Dr. Adler. It was really great.